Good afternoon and welcome to the Assembly of Osteopathic Graduate Medical Educators AOGME webinar series. We are pleased to have you join us for this AOGME webinar on prime rural hospitals for GME development featuring Dr. Emily Hawes and AOGME member Ms. Lori Rodefeld. My name is Austin Wetmore. I'm the program manager for GME initiatives at ACOM, and I will help facilitate this webinar. Before we get started, I would like to review a few housekeeping notes. This webinar is being recorded. The recording will be posted on the AOGME webpage shortly. All webinar participants are in listen-only mode. If you experience technical issues during the webinar, please use the chat feature and we will assist you. If you have questions for the speakers during the webinar, please feel free to submit them through the Q&A feature at any time. If time permits at the end of the webinar, they will respond to your questions. I will now briefly introduce our presenters. Lori Rodefeld, MS, is the director of the Wisconsin Collaborative for Rural GME, and she has worked in medical education for more than 10 years at SSM and Rowe Hospital. She serves as an advisor for the HRSA-funded Rural Residency Planning and Development, RRPD, and Teaching Health Center Planning and Development, THCPD, Technical Assistance Centers, as well as a consultant for the Rural Training Track Collaborative. Emily Hawes, PharmD, is an associate professor in the Department of Family Medicine at the University of North Carolina at Chapel Hill and an associate professor of clinical education at the UNC Eshelman School of Pharmacy. She provides collaborative drug therapy management in a family medicine clinic in rural North Carolina, and her research focuses on team-based primary care, health workforce policy, and GME program development in rural and underserved areas. Thank you again to Ms. Rodefeld and Dr. Hawes for being with us today and for preparing this presentation. With that, I'll turn it over to the speakers.
Thank you so much, Austin. My name is Emily Hawes, as he mentioned, and we are thrilled to be here today, especially speaking to an audience that has made such a difference already for underserved GME. Today, Lori and I are representatives of a larger consortium comprised of people and partners who are all aligned around the mission of expanding GME. So you can see some of our partners listed on the slide. Today, we'll be sharing research and tools to help with outreach for rural GME development. And with that, we'll click to the next slide and list our disclosures. So our technical assistance centers are supported by HRSA, both through the Rural Residency Planning and Development Program and the Teaching Health Center Planning and Development Program. The content of our presentation does not necessarily represent the official views of them. I do want to pause and just say that Lori and I are presenting work that is made possible because of these people listed on the slide. So we have done this in partnership. Mukesh, our PhD grad student, is in the audience today, I believe. And then also we, as part of our consortium, partner closely with the UNC Cecil Sheps Center for Health Services Research with leads Erin Freyer and Dr. Mark Holmes, who really have done a lot of work to make this research possible. We hope that you walk away from our time together understanding characteristics of prime rural hospitals for GME development with regard to volume, clinical mix, financial status, and geography, that you recognize hospital and community characteristics as well as factors associated with hospital categories, and that most importantly, you come away with program development resources to support you wherever you are in the continuum of GME development. And then we certainly want to allow time for questions. So please go ahead and submit them. We want to thank you already for the wonderful questions that you've submitted and look forward to answering them throughout and then during the Q&A session. So as you are aware, there is not enough GME training occurring in rural and underserved areas. The General Accountability Office estimates that only 2% of training is occurring in rural. So fortunately, HRSA, the Health Resources Services Administration, has invested in trying to shift that distribution of training from more metropolitan areas to rural and underserved areas through two programs. The Rural Residency Planning and Development Program, which is awarded $54 million to 73 organizations across 36 states and 6 medical disciplines. Each one of these grant recipients who HRSA selects receives $750,000 to launch a GME program over a 3-year period. Most of our grant recipients are rural health facilities or rural hospitals. The Teaching Health Center Planning and Development Program, which it's in its infancy, it began at the end of 2021, has awarded $46 million to 93 organizations across 36 states and 8 medical and dental specialties. Now, most of these grant recipients are federally qualified health centers and are more in, as you would imagine, in the ambulatory care setting. In 2018, HRSA also funded our Technical Assistance Center to support the development of these grant recipients, but then also provide information to support GME development, which we do through our website. So for our grantees, we provide consultations, advising, education, and community learning. This program that HRSA has developed has already been really impactful. So since the beginning, when the first grant recipients received startup funding, which was in 2019, 39 new accredited rural residencies have been created in family medicine, internal medicine, psychiatry, and general surgery. So this equates to 515 new ACGME approved resident positions in rural. To give you context, in the decade between 2005 to 2015, the GOA estimates that around 400 positions in rural were created. So in just under 4 years with RRPD, HRSA's program has helped create over 500 positions. So it's certainly making a difference. 31 programs have matched 308 residents. 22 programs are actually actively training residents right now. We'll see that number continue to grow over the years as more and more programs have matched into these accredited programs. Hot off the press, I want to share that just last week, HRSA published a forecasted funding opportunity for cohort 6 for RRPD. We encourage you to check this out. The NOFO is anticipated to drop in October with a closure date of around January 2024. So we hope you'll consider applying for for RRPD funding. So we want to share 2 research studies with you today that have implications for outreach for GME expansion and development. First, we conducted a logistic regression to predict whether, well, actually we conducted a bivariate analysis comparing the community characteristics of the first 2 cohort of RRPD programs that were in 40 rural or non-metropolitan counties compared to almost 2,000 non-metropolitan counties in the US that don't have an RRPD program. And you can see this map right here that depicts our RRPD practice sites, 67. So what we did is compare the characteristics of the 40 rural counties with RRPD grantees to the almost 2,000 rural counties that do not currently have an RRPD program. And what we found is that RRPD counties were more populous, had a higher population density, and a higher percent of population that was non-white or Hispanic compared to non-RRPD counties. We will be supplying these slides to you so that you can look at all the details. With respect to income characteristics, RRPD counties had a slightly higher percent of population that was Medicaid eligible and percent of population in poverty. RRPD counties and rural non-RRPD counties were similar in regards to levels of persistent poverty, median income, and the proportion of population that is above 65 years. With respect to provider facility characteristics, RRPD counties were more likely to have a hospital, more hospital beds, and more PCPs per 10,000 population than rural counties that did not have an RRPD training program. So in summary, given that we know that variables are correlated with each other, our team ran a logistic regression to better ascertain those factors associated with being an RRPD county. As you can see on the slide, both higher population and PCP ratio were strong predictors, while the social vulnerability index was a weak predictor of being an RRPD county. So as we've termed, the sweet spot of being an RRPD county is having that critical mass of population and existing physician supply to support patient volumes and preceptors to launch a GME program, yet still being in areas that are more socially vulnerable. These findings were utilized to identify additional counties fitting this sweet spot, and those are those with a social vulnerability index of 1, about 10 PCPs per 10,000 population, and a population of around 98,000 near a metro county fit the profile most similar to RRPD sites. Now, Lori and I'd like to give a caveat that not every program should start a GME program. So we're not trying to prescribe who should start one or not. What we want to share is that each community is unique. And I'm in one myself where a GME program has launched, and we have our own sets of assets and strengths that need to be considered. So we really want this to be used as a tool for outreach, to consider GME partnerships and program launching for this collective effort to see GME grow to improve the health of underserved areas and populations. So that's the first piece of research we wanted to share with you. Now we want to shift to some of the research that we've done around prime rural hospitals. As most of you know, CMS has reimbursement rules that have historically disadvantaged hospitals from starting or expanding residency training in some rural settings. Although there has been progress, the cap has hindered rural hospitals from increasing training slots, and residents who rotated in rural hospitals have inadvertently triggered low per resident amounts, which has made it really challenging for those technically GME naive rural hospitals to launch and sustain future training programs. Thankfully, to address some of these problems, CMS executed regulations as a result of Section 131 of the Consolidated Appropriations Act, which in short allows for resetting of PRAs for some hospitals that have a low or zero PRA, and permits certain hospitals to add cap positions for a new residency program that has historically had low FTE caps. So our team helped develop an algorithm to help make the implications and next steps for Section 131 a little bit more digestible. So we'll walk through this algorithm. We did publish this in Academic Medicine. I encourage you to look at the slides that we send and also check out our article. So the first question to ask in understanding these provisions of Section 131 is, has your program ever claimed residents? And if the answer to that is yes, then the next question is, how many residents were claimed when the initial PRA cap was set? If that's less than or equal to 1 before the Balanced Budget Act, you are considered per Section 131, Category A. If less than or equal to 3 FTEs were trained between the Balanced Budget Act and the Consolidated Appropriation Act of December 2020, then you are considered Category B. Now, if a hospital falls into those categories, and don't worry, we'll tell you how you fall into those categories shortly, what we recommend is that you confirm the accuracy of the PRA or CAP. And then if there are any questions, contact your Medicare administrative contractor, which Lori will go into later, to request a PRA reset and or a resident CAP reset before December 2025. Key point. Going back to where we said yes, how many residents were claimed when the initial PRA was set? If you don't fall into category A or B, then you're considered all other hospitals, which for our analysis, we've termed established teaching hospitals. And again, like you saw in the other green rectangle, we want you to confirm that your hospital is in fact eligible for a PRA cap reset by reviewing Medicare cost reports. Again, we'll review this toward the end. Now, going back to the start of that algorithm, if the answer to has your hospital ever claimed residents is no, then you are considered what we're terming a never claimer or a GME naive hospital. And what we also want you to do is, sounds familiar now, confirm your hospital is in fact a never claimer by reviewing the accuracy of Medicare cost reports. Now, what the Section 131 did is it stated that if you train one or more FTEs in any fiscal cost report year following December 2020, you must begin claiming those resident FTEs as of that cost report year. So it set that threshold that had historically not been there. So what we did as part of our work through the SHUP Center at UNC is we conducted research to describe the characteristics of hospitals categorized under Section 131. And most importantly for this audience, for you, is used a logistic regression to identify rural GME naive or never claimers that are most similar to teaching hospitals. And this represents yet another tool that can be used to determine outreach for GME development. This is the conceptual framework utilized to describe size and clinical mix, financial status, and geographic considerations for hospitals categorized in Section 131, as you can see on the right. What we did is we used the March 2022 release of the Medicare cost reports for financial and operational details, and then the 2022 county health rankings for community characteristic data, and then conducted a bivariate and multivariate analysis. Continuing on with methodology, labor and delivery were defined by having at least 10,000 in charges. With respect to hospitals, we classified them as, you can see, 1, 2, 3 prospective payment systems, 2 rural referral centers and or sole community hospitals, 3 other hospital payment types, which includes Medicare dependent and others. We did exclude critical access hospitals for this analysis, given that GME financing is different for them, but Lori will share that we have definitely seen successful programs launched in critical access hospitals, not only through the 150 grantees that we're supporting, but in other work where we've seen GME development. Rurality was defined as a RUCA or RUCA, depending on how you like to pronounce it, of 4 or greater. With respect to hospital characteristics, let's look at the total sample. So that first column under total sample. About 1/3 of the hospitals were in rural areas. So this is all the hospitals in the Medicare cost report, minus critical access hospitals. 64% had a nursery, almost all had an OR, and about 1/3 were affiliated with a hospital system. What we then did is compared each category to never claimers, and you can see a higher percent of never claimers in rural areas. GME participating hospitals, which includes category A, B, and ETHs, were more likely to be affiliated with a hospital system, have a nursery, and an OR compared to GME naive hospitals. And again, we'll supply these to you because we are breezing through them to get to implications. When looking at financial characteristics, I want to point out the difference in net patient revenue for GME participating hospitals versus never claimers. So you can see in that middle line, looking under never claimer with a mean of almost 79 million for never claimers as compared to almost 400 million for these established teaching hospitals. Across all these GME participating categories compared to the never claimers, we see a higher number of acute beds, higher acute average daily census, and longer miles to any hospitals or rural referral centers. In summary, the established teaching hospitals had the highest net patient revenue. Category B hospitals had highest median total margin, while never claimers and established teaching hospitals had the lowest. The median aerial distance from never claimers to any closest hospital was about 10 miles, and to the nearest hospital with at least 150 average daily census was 22.6. And then in the next bullet, you see much closer proximity for the established teaching hospitals. Out of the over 1,500 GME participating hospitals, 11.3% were located in rural. The take-home point for this slide is bullet 4. Net patient revenue was the strongest predictor of being a GME hospital, and rurality was not a factor in determining the GME category after adjusting for other hospital characteristics. Turning to community characteristics. The GME naive hospital served an older population, those with a higher age-adjusted death rate, and greater proportion of non-Hispanic populations compared to all the other categories. The never claimer hospitals cared for a greater portion of uninsured adults compared to those category B, and uninsured children compared to all of the other categories. The never claimer hospitals are located in communities, again, this is not surprising based on the other research we know, with a lower availability of PCPs, dentists, and mental health providers. So this slide to me highlights that these are the exact communities that we want to bring GME programs to. It's really a health equity issue, which is something that I think we can all align on, is shifting that distribution of training to help address the health of these communities. I'm going to let you refer to these slides later so we can shift into some of the implications and next steps as well as your questions, but we will include them as a PDF for you. So finally, the implications that we're really excited to share with you today. This analysis helped us identify 145 GME naive hospitals who seem to fit the characteristics or look similar to teaching hospitals that may be targeted for outreach to consider evaluating fit for starting a GME program. This includes 6 category A's, 75 category B's, and 64 established teaching hospitals among the rural never claimers. So among these never claimer hospitals, this table, I really like this table. It kind of makes it a little bit more applicable. It shows the descriptors of the top 10 rural never claimer hospitals with the lowest probability of being a never claimer, or if you will, the highest probability of becoming a GME hospital. So those that seem to fit the characteristics that are similar to hospitals with GME expenses. So looking at these top 10, you see that most hospitals are located in the South region. They have average daily census ranging from 99 to 283. 7 out of 10 of these hospitals are system affiliated. Net patient revenue ranges from 283 all the way to 777 million. Total margin ranges from 1.7 to 27.3. The distance to the nearest hospital with at least 150 ADC ranges from 22.6 miles all the way to 111 miles. And Lori is going to share with you where you can search to find if you have one of these prime rural hospitals in your region. And I want to share, this is early in development, but just this week, Mukesh, our PhD student, evaluated the overlap between the counties that look similar to RRPD counties, so that first research that I showed you, and the counties that house prime rural hospitals, and put that, looked at those together. So in short, the higher that number, i.e. the green, the more sweet the probability or similarity to RRPD counties and established teaching counties. And we are going to put this data in our toolbox, but this is just hot off the press. So now I'm going to turn it over to my partner, Lori, to share more about implications, tools, and resources.
Great. Thank you so much, Emily, for setting the stage for I think the fun part of the discussion, where we can actually share with you some of the resources, some of the tools and information to help you if you are looking at reaching out to some of these prime rural hospitals and how to find what these prime rural hospitals are. So my hope is that most of you have a login and password for our rural GME site. If you don't, it's really easy to register. The green button right there. You would just enter your email along with a password, and you can get free access to our portal. To log into the portal, it's really easy. You just go up to the right-hand side of that website and you'll click the link, and you'll be just amazed at all the tools and resources that we have available on Rural GME. So next slide, Emily. We have a toolbox. When you log in, your login will look different than mine. I'm an advisor. I have programs that I work with, so I have a programs link down below. If you're an RRPD grantee, you should be able to log in as a program. But for just general users, you have access to get started, and that actually has a timeline for program development. And I really encourage you, if you are reaching out to a program or a potential program, a hospital that you're partnering with, to look at that timeline and look at how long it takes to start a new program. It typically takes at least 2 to 3 years to start a new rural residency program. You want to make sure that you don't rush it, you do it right, and you really we'll go through a roadmap that shows all the different steps that are involved. But again, our goal is to create high quality programs. So again, take the time to get it right. And in our toolbox, we have a number of different resources to help new programs, help existing programs with their GME development journey. And if you click on that toolbox link, what I do, and it's probably just kind of the quicker way to get to the Prime Hospitals file, is you can search for Prime Hospitals, Prime Rural Hospitals, and you'll be able to access our Excel file. And what you'll see when you click those search terms in our toolbox, you'll see a link just like that. And when you click on it, you will be directed to the Excel file, which is on the next slide, Emily. And we actually have a really great kind of searchable Excel file that is available to everyone in our portal. And what's really great is you can search it, the whole list for the whole country, and you can filter, you can sort using those little buttons at the top. So if you want to search your region, say you're in Illinois, you're looking at maybe Wisconsin, you're looking at Iowa, you're looking at Michigan, you can kind of filter by state, and you can see which prime rural hospitals are in your region. Or at the bottom of the spreadsheet, which it's so big we can't show all of that, you can just click the tab for state, and this is the state tab for North Carolina. And you'll see in here it does show some of those key metrics that Emily was talking about. So you'll see the average daily census is listed, if they have a system affiliation, the revenue, the margin, and the average daily census. So just for an example, we decided to kind of pull out the Pinehurst, North Carolina hospital as an example. I do recommend that if you are approaching a hospital, looking at a hospital, that you utilize the Hospital Analyzer tool. The Hospital Analyzer tool will allow you to kind of see what the funding situation is for that particular rural hospital. So next slide, Emily. I'm going to show you how to get to the Hospital Analyzer. So the Hospital Analyzer is in our portal. It is in our toolbox, and that's going to be up in the upper right-hand corner. It's just called Hospital Analyzer. When you click on that, you can actually sort by state. So you'll see I selected North Carolina here, but you can select any state, and you can actually look at any state and any hospital, whether they're rural or not, in our Hospital Analyzer tool, and it will tell you whether they're rural or urban. It will tell you kind of their hospital type. Hospital type does drive funding. So Emily, next slide, I'll show them the PDF. So this is the Pinehurst, North Carolina hospital that we had identified earlier as a prime rural hospital. In this particular example, the PDF shows the different definitions of rural that matter with regard to funding. There's a lot of different rural definitions. I learned from Randy Longenecker that there's actually 75 different rural definitions out there, but the 3 that matter for funding are going to be the OMB definition, the CMS definition, and then the FORP definition. So again, those are the things that are going to, make an impact with regard to finance. And then the hospital type will be listed, and you'll see that it's kind of shaded in pink if that, is that particular hospital. So in this example with Pinehurst, they are a rural referral center, and they are a never claimer. So again, a never claimer is a hospital that has never claimed residents to date. They may have not missed claiming residents, but CMS does not have a record of them claiming residents. So again, this hospital does appear to be a good candidate for GME with regard to all the metrics we were talking about, but then also with regard to funding. I also want to give recognition to a really great glossary that's available. When you see click for more detail, go back to the slide, Emily. It says click for more detail. That will take you directly to the glossary. And we actually have a 7-page glossary, next slide, Emily, that shows you, just all the different definitions, what those definitions mean, and what the funding implications are. Now, GME finance is very complicated. It's very complex. And, there are a lot of great consulting organizations out there. So again, if you feel like, you're in over your head a little bit with finance, don't be afraid to seek out some expertise to help that hospital, because funding is complicated. It takes a lot of time and energy to understand it. And fortunately, AOGME has been doing some wonderful webinars on financing. So watch those. In our toolbox, we'll provide some recommended webinars. You can watch those. So again, you can kind of get a really good understanding with a lot of the things that are out there. But if you feel like it's getting really complicated, maybe it's a Medicare dependent hospital, or it's a sole community hospital, or there's something that seems a little uncertain, don't be afraid to, again, get it right, understand the financing, and invest at the start versus making a mistake later. But our glossary is a really great tool. So as we look at working with these prime rural hospitals, again, the first step that you want to do, if you see a hospital that's in your area, maybe you already have a relationship with them, maybe you're sending your students to that hospital for some rotations, they're probably a really great site to reach out to. But again, before you start those discussions, you do want to go to the hospital analyzer to identify, what's their current situation. And what I'll often do if I'm working with a hospital is I'll print that off and give that to them. Here's what the hospital analyzer says. This is kind of where we think you are, and this is what the funding implication could be. And again, I think the research shows that some hospitals are better positioned to not only help set up and stand up a program, but then they're also set up more advantageously just with regard to their hospital type. And the hospital analyzer glossary is going to give you a nice overview of that. And I think probably a key takeaway is that a hospital that's category A or B, they need to work on getting their CAP reset or their PRA reset by December of 2025. This is not something that will probably ever be available to them again. So we really want you to have them reach out to their Medicare administrative contractor. There are different contractors for different regions, and you want to have formal communication with a MAC. You want to have a letter. You want to have a response from the MAC. You want to have that well documented regarding a CAP reset or a PRA reset. And then most importantly, you need to have that hospital start training residents. They need to start training residents before 2025. So ideally like 2024, 2025, they should be starting programs so that they can reset the CAP or they can reset their PRA. And then lastly, this is an important piece, and this is something we'll talk about more in the Q&A, is you really want to understand what is the Medicaid GME situation or what state funding may be available to those hospitals to help support GME. There's a lot of really great innovation happening. I'll mention some of the states later when we look at what state funding is out there. I also know the GME Development Institute. We had Charlie Alfaro. He's one of our TAC advisors. He did a really great session on Medicaid GME funding, and he's a really great expert when it comes to Medicaid GME. But again, that is just something that can either help support development of a program or expansion of a program, or even just supplement the funding that the program receives. So while the analysis shows that patient revenue is the strongest predictor of GME status, there are hospitals that are also looking at what's their comprehensive nature of services. What are they in a system? What resources do they have to create a great training program? But in the next slide, you'll see that isn't everything. Like Emily said, this is a tool. This is a guide for hospitals that may be in a good position to set up residency programs. But we know that there are many hospitals out there that do set up great programs that maybe aren't on a prime list, but they have decent margins, they have decent volumes, and I really want to call out our smaller hospitals like critical access hospitals. There are many excellent RRPD grantees in Wisconsin where I'm located. We have 4 new family medicine rural programs that were created. 2 of the 4 are in critical access hospitals. We've got a 5th that's in a 2 critical access hospitals partnering together, and they're setting up excellent programs. So again, while this list is a guide, it's not the only tool out there to create excellent rural programs. And really, this is just something to consider. But I do think it's important to note that, if you are having conversations with CAS or with other rural hospitals that are not on this list, that you do want to talk about volumes. You do want to talk about margins. You do want to talk about, the culture, what relationships are available, what community assets do you have? Those are all just as important in developing a program. And then lastly, we are seeing, I think, a really exciting movement, local partnerships, statewide partnerships, and national partnerships to really grow GME in rural and underserved areas. AOGME is a great example of this. There are great partners with rural GME and THC GME. And, again, I think that there's a lot of really great work happening at all levels to grow rural GME. And then, as I mentioned, Medicaid GME in the states really helps support not only program development, it can support expansion, and it can support technical assistance. So getting back to our toolbox, again, we love our toolbox. It's got a lot of really great resources. And there's kind of 6 main categories of the tools and resources that are available. There are resources related to program accreditation, everything from navigating a site visit to preparing an application to financial planning, program design and development, and several webinars. So again, the webinars, I'll give you a list of recommended webinars, but there are a lot of really great resources out there. If you find a prime rural hospital that is looking to engage in this, there are a lot of tools available to them, even if they're not a grantee for RRPD. This is available to everyone. Anyone can set up an account. And I think what's really great is if you sign up for our tools and resources, you actually get emailed if we're hosting a webinar. If we have, a newsletter, we have exciting updates to share. You'll get that from either Rural GME. And then we also have a partner site, THC GME. So if you are interested in teaching health centers, community health centers, there's other resources there as well. So definitely take advantage of all of these opportunities, because, really our goal in offering these is to help hospitals grow and thrive in creating GME programs. So this is our roadmap. And one of the questions we received is, how do you get started? Do you have a timeline for development? In addition to the timeline for development, we have this really great roadmap, which, it looks like it's a linear approach, right? Because there's stage 1, 2, 3, and 4, and 5, but really it's non-linear. I mean, these things can happen in a variety of different ways. You may have a program director right out of the gate, and if you do, that's awesome. You're going to have a great program, but you can't ignore any of these steps or stages. This is really an evidence-based approach to developing and designing a strong and successful program. And as a technical assistance center, as advisors, we work with grantees on every one of these steps and stages to make sure that they are successful and to make sure that really they can be sustained within the long haul. But I'm going to talk a little bit about exploration in the next slide. I think that that's probably one of the biggest steps as you're approaching a prime GME hospital. You want to really dig into that exploration. And I want to give credit to Randy Longenecker and the RTT Collaborative. They have a really great resource on their website. It's called TREES. And TREES is actually this really great assessment that you can give to a rural hospital and ask them to complete, ask them to really take a look at what assets do they have in their rural community or in their hospital to really, see how ready they are with regard to creating a new GME program. So first, in getting started with exploration, you do want to engage with the community. You want to build that coalition of invested stakeholders. A lot of times you'll see a hospital president who thinks, oh, I want to start a residency program. They don't know how long it's going to take, how much money it's going to cost, and then they don't even know if the physicians are on board. So again, you want to make sure that those physician stakeholders, they there is maybe a physician champion, and more importantly, the local community is really ready for this because the GME program needs to be successful, and it takes a village to create a strong rural program. You want to assess readiness. Again, if you have that hospital president that has this dream, but the rest of the team isn't on board, it's probably not the right time for a residency program to start. That may be an opportunity to then say, hey, how about we partner with you on some UME rotations? Let's get some med students in the hospital. Let's, see how that goes. Let's identify physicians who are enthusiastic about teaching, and then we can revisit the idea of starting a residency program. You also want to take some time and explore the community capacity. You want to look at, what assets are there? What gaps maybe does the hospital have? Are there any limits or limitations? Are there any things that maybe they can't provide that they may need to partner with an urban site or an urban program for? You want to enlist leaders, physicians, and staff in the process. I think physicians are probably the biggest key in addition to the leaders. You need champions on both sides. And then you want to explore partnerships. Hopefully, as osteopathic medical partners, you're already a partner in that process, but there could be other really unique partnerships you could leverage, working with the VA, working with tribal partners, working with your local AHEC. There are a lot of possible partners that can help make this program strong. And again, that's where this trees document is such a great way for the kind of rural hospital to identify, what do we have, what don't we have, and how can we create a program that's going to be unique to our community and ultimately successful. And I want to, just kind of wrap up with some recommended webinars. And we are so thankful for all of the questions we got ahead of time, because this allowed us to kind of shape and frame up the webinar recommendation. So we have many webinars, and again, you'll get this you'll get the slide sent to you. So please take a look at these webinars, because they really do cover a lot of the questions regarding funding, how to create residencies outside of family medicine. So if you're looking at IM or psychiatry, surgery, OB-GYN, we have webinars that kind of cover all of those things. Governance and hospital support. Governance is a big thing. Talking with the leaders and stakeholders about why you're creating a residency program. That's really important, and watching those webinars in advance is helpful, or having any hospital partners refer to those webinars is also helpful. And then lastly, program development. There were some questions around, how do you recruit faculty or program directors? How do you prepare your institution for a learner? We have webinars on those topics as well. And again, I encourage you to, sign up and create that account so you can get access to all of our webinars that are coming up. So with all of that, this is our contact information. Don't hesitate to reach out. If you have questions, we're here to answer them. We're here to support the development of rural GME and underserved GME. And with that, Emily is going to ask me some questions, and hopefully we'll also have some time to answer any questions that came into the chat.
Wonderful. Okay, thank you so much, Lori. First up, how do we fund small programs in rural areas that do not meet the ACGME standards?
Yes, so I think this question, I'm going to kind of refer to my experience in Wisconsin. One of the things that we did with WCRGME and setting up a technical assistance center is we really tried to leverage partnerships, and we had many hospitals that maybe weren't ready to start a GME program, but they were ready to kind of test the waters a little bit or be a partner with another program. So we actually have several rural hospitals that work with our surgery program, our psychiatry program, our OB-GYN program, and they serve as a rotation site. And if they're a prime rural hospital and they're interested in kind of testing the waters, maybe they don't have the volumes, but they can be a partner, they can rotate at a rural hospital site, but you want to keep them under the 1.0 FTE so they don't inadvertently set a cap. So again, that's where, they need to have someone who's monitoring the rotations, making sure that, you're not having too many residents rotate, but that's one model. I think the other experience that I've had in Wisconsin, and that I've seen even with RRPD, is setting up residency and critical access hospitals. So maybe it's two hospitals working together. Those could be two prime rural hospitals, two non-prime rural hospitals that work together with an urban partner. And, together all three hospitals can develop a really successful residency program. So again, they may not be able to meet all of the requirements, see which requirements they can meet and how they can be a partner, because they may have a good culture, have some really great unique learning experiences, and not every hospital maybe can hold a standalone program, but there are many opportunities and ways to do it if you think creatively.
Thank you. What are strategies to ensure adequate funding, and which states provide the most funding for new GME or GME sustainability?
So the states that are doing a really great job with GME that come to mind would be like New Mexico. They have, I think, a really great system set up where they have Medicaid GME, they have funds for program development, and even to the point where they're supporting and funding programs above the cap with Medicaid supplemental funding. Similarly, Florida is doing a really great job. There's a lot of supplemental funding, and Wisconsin. We just were able to successfully get our expansion grant amount increased to $150,000. And then also from our state perspective, we've been able to fund program development of $750,000, similar to what HRSA provides for RRPD.
Wonderful. How do you attract participation from underrepresented medical specialties like pediatrics and psychiatry?
Yes, and those are specialties that are a little more difficult to set up and establish. And that's in Wisconsin. What I've seen is really strong partnerships. So we have our Medical College of Wisconsin. We set up two programs, and they really work with a variety of different hospitals. It's really hard to set up a psychiatry residency program in just one site. You need a number of partners. Again, it takes a village to create those programs and those partnerships. Similarly, pediatrics, that's harder to set up just because of the inpatient rotation requirements, but we have seen successful rural programs get launched. But again, it's through partnerships, maybe with an urban hospital and then a rural hospital that has significant volume to support that.
And then once you start these programs, is it hard to recruit medical students to these rural programs?
I would say on the osteopathic side, we have a number of applicants. And I would say in general, we have not had programs that have not filled their classes. We have a lot of medical students, especially one thing that I really advocate for in Wisconsin and with any new grantees that I'm working with RRPD or THCPD is to establish partnerships with our osteopathic partners, especially because those students are more likely to go into our primary care specialties. But we do really encourage partnerships and, kind of creating almost like a pipeline, right? You bring in those students for rotations, they have a great experience, and then they become your future residents.
Great. And then how does GME development considerations, or how do GME development considerations change for residency development in ambulatory care sites? So those that are sponsored by an ambulatory care health facility, like
Yes.
FQHC.
Yes, there are several of our, teaching health center grantees that are rural. I think we have 13 at last count. And we have many of our RRPD grantees that even partner with, their local FQHC or Indian or tribal clinics. And the accreditation requirements are the same. It's just the focus of the training is a little bit different. It's going to be a little more ambulatory focused. And we're seeing great success with those programs. They are just, I think, thriving in focusing more on the community needs and a little less on the inpatient side of things. Just thinking about, one of my grantees on the THCPD side, they've really been able to dive into health equity issues and, really provide a different kind of training experience.
Wonderful. And another question that just came in that is also related to the Consolidated Appropriations Act that we didn't cover today. Do we need separate ACGME accreditation for a rural track?
So there are many different ways to create a rural program, and there is a program expansion option that ACGME has allowed. I would refer to the ACGME RTP website, where there is much more specific detail and information than what we'll be able to cover right now, but you can expand programs and receive funding for such expansions with the new Consolidated Appropriations Act rules. So again, it's a great opportunity. There's been a lot of positive change with the Consolidated Appropriations Act.
And some of our grantees are among some of the first to ever have non-separately accredited programs through this new approach at ACGME. So it's exciting to see. Next question, what are some methods to get physicians to buy in? And how do we identify and develop prime administrative and physician faculty champions?
Having physician champions and having a strong cohort of interested physicians is probably the deal breaker for most programs that are getting off the ground. I would say having a strong contingent of interested faculty who want to teach, who want to share, who want to be invested in the process is what's going to make the program stand out. So I think that, again, the best way to start this is through, some initial training, whether that's PA students, whether that's nurse practitioner students, medical students, or even, getting the physician's feet wet with some rotations. As long as you standard that 1.0 FTE limit, you can have residents rotate. You can, kind of test the waters a little bit with regard to GME and create some interest and some enthusiasm. But again, I think, it's helping them understand the why. And I think that there's a lot of reasons why programs start, but usually it's, there's a strong foundation, there's, strong commitment from administration, and there's a strong commitment from the physician group, and they see the need. And again, they've hopefully had some experience in it, although that's not required. You can set up a really great residency program if there isn't a history of student training or resident training, but it definitely helps.
Wonderful. So what are some of the best places you've found for attracting program directors for starting rural residency programs? And do these rural program directors need previous GME experience to be a director?
Yeah, so there's definitely not a one size fits all approach to recruiting a program director. We've seen a lot of programs grow their own, and that kind of connects to, do they need to have previous GME experience to be a rural program director? And the answer is actually no. It helps. They should be involved in a CCC or a PEC. If you're a rural program and you have an urban partner, you could get a faculty appointment. You could get some experience or exposure teaching residents, but you don't necessarily need to have years and years of experience in GME. I've seen new programs get accredited that, they'll enroll their program director in NIPID, for example, and maybe they've taught some medical students and they are still able to get accredited and get the program started. So again, I think, they're looking for leadership experience. They're looking for, you have to look at each specialty's requirements, but with the, different tools and resources out there, you can recruit a program director without much issue. There's also other resources like 3RNet. There are other resources like networking at conferences. We actually were at the AAFP conference a couple of weeks ago, and one of our Wisconsin programs hadn't recruited a program director for 2 years. It's an existing program and they're looking to replace someone. They actually made a really great connection at the AAFP conference. So again, it's a lot of times through relationships and networking that you'll be able to identify a program director.
Wonderful. Please describe important distinctions between hospitals that are ready versus not ready for GME activity.
So again, I think, our research shows the prime hospitals' financial considerations were a big piece of their ability to, become a teaching hospital, although finances aren't a deal breaker. What we've seen in our RRPD work, we've done some analysis with the sweet spot research, that finances can be a challenge. That's why, we were really emphasizing using the hospital analyzer tool, using the resources that are already available in the Rural GME portal to understand the financial situation for each hospital. The other thing that will, kind of make or break a hospital is if they can recruit a program director or if they can recruit faculty. Without those pieces, it's almost impossible to start a program. So again, that is probably one of the first considerations is, do you have a program director? Do you have faculty? Do you have physicians who are invested? If yes, the other pieces can fall into place. Again, you have 2 to 3 years to get the program launched, and you may not have everything right away, but if you have enough of a foundation, you should be able to move forward.
Great summary, and these questions are right in line with what our data and the information that we're gleaning from the grantees, which is GME financing and faculty recruitment, specifically program director recruitment, are kind of the top barriers, but also can be huge facilitators when you find kind of the right fit and a sustainable future looking ahead. How do we help organizations that are needing funding support? And also, can you touch on housing development and assistance with establishing a GME program?
That is such an important question, right? Because you look at hospitals and their local communities and what resources are available. And I've been really impressed with some of the hospitals and programs that I've worked with and seen how they really engage their local community and their local stakeholders. So for example, there's one of my RRPD grantees. They've actually really engaged with their local community hospital foundation, and they actually have a really nice fund that's available to help support residency operations. And that's just kind of a creative approach. Another grantee that I've worked with, they actually were able to get some funds for housing through grants that can help support residents, because housing is a big concern. We're seeing growing shortages in rural housing that impacts all of our workforce. It's hard to recruit any providers, whether that's nurses or physicians, to communities if they don't have a place to live. Another one of my grantees for RRPD, they actually, the hospital owns several houses, and these are really nice houses, and they're actually gifting those to the residents. So the residents can live in the houses, and they don't have to worry about finding a place to live. They can just, and these are really nice, like brick Victorian houses. So again, I think rural hospitals have no choice but to be creative in how they approach just these different issues. But again, when you engage with that local community, you can really make an impact in helping them see the need and finding ways to invest in the program.
And innovatively market to their program, and hopefully
Yes.
long term their community that they'll stay in. Last question, because I know we're running up on the end of time. Any strategies, Lori, for inpatient peds rotations?
Yeah, so inpatient peds rotations, and I'm guessing that this question is specific to family medicine programs. Inpatient peds requirements, fortunately, with the new program requirements, have been scaled back slightly. So the burden isn't as high for programs looking to establish, those inpatient pediatrics rotations, but that experience is still needed. And if you're in a rural area and you're not very close to a nearby children's hospital, it can be a challenge. But, I think, for those family medicine programs, they need to just cast a net far and wide. I've got a grantee that is in it's in Oklahoma, and they are looking as far away as Florida for a inpatient pediatrics rotation. And it's not ideal, but you can provide housing, travel, make accommodations so that those requirements can be met. So again, you have to think creatively sometimes and cast a wide net and see where you can find those experiences. But some rural hospitals, again, our prime rural hospitals, they may have enough pediatric inpatient volume to sustain the inpatient peds requirement. So again, really looking at what resources do you have in your local area, but then if you need to cast that net a little bit wider, chances are you will find something, but it may not be an ideal situation, but it will still meet the requirement and still get your residents the training that they need.
Wonderful. Well, thank you so much. I think that concludes our questions. Austin?
Yeah, thank you so much, Dr. Hawes and Ms. Rodefeld, for this great presentation, and to all who joined us. As a reminder, a recording of this webinar and the slides will be made available soon on the AOGME webpage. If you have any questions, please contact us directly at aogme@acom.org. This concludes our webinar. Thanks again to everyone who joined us, and have a great evening.
Thank you. Bye.
Thanks.